Well, good morning, good afternoon, and good evening to everyone. I'd like to thank you for joining us today for today's webinar, Aligning Strategy and Human Capital at the National Health Service. My name is Karen Luce. I'm the Director of Learning and Development here at Denison Consulting, and I'm your host for today's webinar. And I'm joined by another Karen, Karen Jones of the National Health Service of County Durham in the United Kingdom. Before we get started, I want to go over just a couple technical things with you. We'll present for about 40 minutes, and then we'll use the remainder of our time to go over some questions that are sent in by the audience. On the right-hand side of your screen, you're going to see a control panel. You can use that panel to send in questions that you have during the presentation. We ask you to please send in your questions throughout the presentation rather than waiting for the end, as this gives us some time to organize them and make the most of that question and answer session. We'll try to get through as many questions as we can, and we do apologize if we don't get to your specific question, but we'll make every effort to follow up with you after the webinar is over today. I also want to let everybody know that a copy of today's webinar is going to be archived onto our website, so if you'd like to view it again or share it with your colleagues, it will be available. We'll email all of you once it is up there. And now I'd like to get started. I'd like to introduce to you Karen Jones. Karen is the Corporate Improvement Team Leader at the National Health System of County Durham. Karen leads the work on the organizational culture initiatives within NHS and has done some extraordinary work in helping to align the people and the strategy within the organization. And with that, I will turn it over to Ms. Jones.
Okay, thank you, Karen. Good afternoon to everybody from the UK. I thought I'd probably just start by giving you a little introduction to the National Health Service as we know it in England. It was started in 1948, and really it was born out of a very long held ideal that good healthcare should be available to all, regardless of your wealth or your ability to pay, and that as a principle remains at the fundamental heart of the NHS today. In 1948, the service didn't really change as such, but it became accessible to everybody regardless of your ability to pay, and as I say, that we hold that dear today. And although we pay our taxes, I think often as a nation we tend to forget that, and we're generally very grateful for the service that's there for us on a daily basis with no kind of official exchange of money. So I just also thought I'd give you a quick kind of rundown of some of the kind of big policy changes that we've had in the NHS. And as I said before, it sort of emerged from an emergency medical service, started in 1948 when we were all a bit war-weary but disciplined and used to austerity. So it hasn't evolved with a demand for generosity, but a real kind of care of having something basic that was there for everybody regardless of their ability to pay, as I've said before. But it wasn't until 1984 that we had the sort of general management concept being introduced, where we had one individual at every level being responsible or accountable for the planning and implementation of decisions. And this led to more sort of flexibility in team structures and a greater emphasis on clear leadership in the 1980s. And doctors, really it wasn't until the 1980s that doctors became much more encouraged to be involved in the budgetary decisions and really sort of focusing in on where the finances went rather than purely the clinical services. In 1989 we had something called the purchaser-provider split, where for the first time purchasers were separated out from the people providing the services, and they were given budgets to buy healthcare from the providers. To become a provider back in the late 80s, you had to become an NHS trust, you had to be independent, and this led to quite a lot of competition between the trusts. And by 1995 all providers were of this trust status. But what we learned from that was the internal market, although it improved the cost consciousness, it led sometimes to very unnecessary duplication of services. And then in the late 90s, we began to sort of realize that actually partnership had to become really important, and we needed to be driven by performance. So in 2000 we had something called the Commission for Health Improvement, and this was really for the first time for us that chief executives of acute trusts were held to account not only for the financial balance of their books, but actually for the quality of the services that they provided. We had the introduction of something called foundation trusts, which enabled our hospitals to become independent and free from management. We had something called payment by results, where we would pay the hospitals for the results in terms of infection or readmission rates rather than just kind of a big bulk contract. And we introduced something called national tariff, where historically commissioners would just give the hospital a huge amount of finance, and we wouldn't really have segmented that for delivery. But with the national tariff, we then said, okay, if you're doing a hip replacement, we would suggest that a national price for that would be, say, £1,500. If you were an efficient hospital and you could deliver that within 1,200, you'd make a profit. But if it cost you 1,800, then you probably don't need me to tell you what would happen to your business. And we also then had something called the National Institute of Clinical Evidence, which was a national body that began to look at the evidence base for clinical decisions and interventions. So that was a huge kind of change for us in terms of where quality began to drive some of the performances. And now in 2010 we have the latest policy, which is called Liberating the NHS, and that's really where management and managers are now being challenged by a new coalition government, and really they're trying to now drive the commissioning of services back into the hands of the general practitioners. And we've had a Secretary of State now that's been in shadow government for 6 years, so he's got well thought through policies, but I think the downside of that is that because he was a shadow Secretary of State, nobody really challenged some of his policies, and now he's implementing them. So it's a great upheaval really for the NHS, and I'll kind of bring us back to that point later on in the presentation. So when we talk about the NHS, if there is indeed a national health service, it's huge. It's one of the largest employers in the world, along with the Chinese People's Liberation Army and the Indian Railways, and Walmart, your supermarket chain, which I think you'd relate to. It employs in its entirety across the nation 1.3 million people, and that's approximately 1 in 23 people working within our working population are connected to the NHS. 77% of its workforce are females. There's lots of volunteering roles that people can take part in, and nurses make up the largest part of the NHS workforce at just under 30%. So that's the NHS nationally. Where am I based locally? As you see, I'm in kind of just to the middle of the United Kingdom. If we look at Scotland, we're just kind of under Scotland, and I'm in a commissioning organisation called County Durham and Darlington. We launched ourselves as an organisation in October 2006, and we serve around a population of 600,000 people. Now our budget is 1.2 billion, and that works out that as a commissioner we spend on behalf of each person in our geographical area around £1,700 per year. So what's our role? Our role is to sorry, I'm just waiting for the slide to jump ahead. Our role is then to engage with local people. Oh, sorry. I must learn to be patient for this. Our role is to engage with local people to improve health and well-being, and indeed reduce health inequalities. So we're very much interested in preventing people from becoming ill in the first place. And to, as commissioners, which is a term I'll explain in a while, to ensure that patients have access to and a choice of a range of high-quality health services by commissioning services within our allocated resources. And that for us is our 1.2 billion each year on behalf of our 600,000 population that we commission services on behalf of. Now, within this presentation and as an organisation, it's quite a complex business to commission services on that kind of scale. So we employed a company to come in and try to develop our story as an organisation using everyday language to describe what we're trying to achieve. And each chapter describes our journey and offers an opportunity for indeed our staff and our partners to really think through how they contribute to that story in itself. And what I've tried to do is take these 6 chapter headings as I present to you our story around culture and what we've tried to do to develop it. So chapter 1 would be our pride and our purpose, and we worked with the top team and senior leaders to think about what we were proud about this organisation and what role does that play, what's our core purpose and why are we different, and what experience and skill and capability do we bring. Chapter 2 is about our current reality, so what is our current performance and what are the implications for that both internally and externally. So what do we need to change and improve? And obviously for us I'll be presenting our results of our survey for that. Chapter 3 looks at our opportunities and challenges, and Chapter 4 begins to describe the journey that we need to make in response to those challenges. And Chapter 5, the role we need to play, so what values do we hold dear and how do we need to pursue those. And Chapter 6 is about our desired destination, so I share with you what our longer term view of our culture was. So let's take Chapter 1 first of all, our pride and our purpose. So as an organisation we had a vision which was to deliver excellence today for a healthier tomorrow for those 600,000 people that we are commissioning health services for. Our mission then was to improve the health status of our population because that would be our measure of success. We were currently employing 500 commissioning staff and we had headquarters based in 8 sites across the city. We also have 4 strategic main aims as an organisation, and this really follows the lifeline of our population. So our first strategic aim was to give children a better start in life. Second was to help our public keep healthy and make sure they need as little healthcare intervention as possible. Third was to ensuring high quality care at the most appropriate time and place, and we have 2 strands of work looking at planned and unplanned care. And finally helping people get the most out of later life. Now, we did currently employ 500 staff, but we're now been faced with the new Liberating the NHS policy statement of a 48% reduction in management costs that we have to make by November this year. So you can imagine the impact that that's had on our culture and people's perception of it. So we're now tasked with making a management cost reduction from 14 million to 7 million by November. So that obviously has a huge part to play in where we are today. So keeping to Chapter 1, which is our pride and our purpose, from using the storytelling approach, we developed some killer facts and some proof points to begin to illustrate to our staff and indeed our partners what we were actually attempting to do and to really bring about our business to life for staff in key sort of details. And you know, the fact that we have 1 in 10 patients admitted to hospital at risk of being harmed, which equated to nearly 2 busloads per week for us across County Durham and Darlington, was a killer fact that we wanted staff and our partners to be aware of and to be really looking at how they all worked and made their contribution to reducing that risk. We had orthodontic, dental works, waiting time in primary care for teenagers. That was at 1.4 years and we've reduced that to 34 weeks. That was a proof point. And we set ourselves some challenging targets over the next 3 years. We wanted to reduce teenage conception rate by up to 180 in each locality. So that we used that to enable staff to begin to make their own personal targets about what their contribution was at a local level to reducing some of those teenage conceptions. And again, we aim to reduce cancers caused by death in the area by 230 patients per year by 2013. So in using the killer facts and proof points, we wanted to engage staff to really begin to see where their contribution was to making these business objectives. And as you can see at the bottom, we had our 5 corporate values, which sits very firmly in consistency from the Denison Model. And we created these the fairness, integrity, respect, trust and honesty at our first innovation conference. And our challenge really was to begin to bring those words to life. So how would we define honesty as commissioners? What would integrity look like? What would what would staff and patients need to be seeing and feeling if we were fair in our role as commissioners. And so what do I mean by commissioning? We really wanted to be clear about what our business was as commissioners. It was a fairly new activity to get very specialised in commissioning services. Currently, as I said before, we would just give the hospitals about 80% of our budget, and they would deliver the services that they had always historically delivered. So we did quite a lot of work taking 100 people out of our organisation and really beginning to develop our value stream map really for what commissioning was all about. And we had sort of 6 key stages of that work. The first was to really understand and gain knowledge and intelligence around our population. So what were their health needs, what were their predicted health needs, how are we going to future-proof services, and what new services may they need in 10, 20 years' time. Once we use that demographic and that public health data, we then have to get to grips with over the next year. So we had an annual operating plan, and then we would have to go out to test the market. So did we have providers able to provide that services for the population's needs, and if we didn't, how were we going to develop those new markets and those new providers? And then really some of the real, once we've looked at that, we have to be thinking, how do we procure those kinds of services? So how do we buy those services? How do we sign service specifications? And therefore, how can we contract, monitor, and performance manage? So this became our business commissioning flow. And for us, this was one of our major challenges around our coordination and integration. So let me just share with you our chapter 2, which is looking at our current reality from our culture data. Let me just get that slide up. So where did we start from? As I said, the organisation was created in 2006 and I joined in 2007. Before that time, my boss, who was the Director of Innovation, had been working on this idea of an intervention called Do It Once, Do It Right. And within that, there was 3 major interventions within that process. So we had the lean management method, which was our chosen method to really understand value and waste. We wanted staff that would be coaches rather than instructors, based on the 3 principles that coaching increases self-awareness, self-belief and responsibility to act, and that instruction generally tends to reduce all 3 of those. And we now have 170 staff through those coaching programs. We also had some authentic leadership programs going on, and we were providing supervision for managers having those coaching conversations. And we also had something called projects for improvement, and we used a technique called walk the walls. So where we had our major corporate projects that we wanted to escalate the priority of, really, we would fortnightly walk the wall to the chief exec. The sponsor director would walk the wall to the chief exec, where she could update on the project's progress, and that would be very visible for all the other directors, and we would begin to look at the cross-functional aspect of making those projects a success. So when I came into post, one of my objectives was to create a culture, a good culture. And obviously, coming from public health, when I get asked to do something, my challenge was to say, okay, how would I know in 1 or 2 years' time that I have created a better culture for this organisation? And at the same time, we were beginning to talk from the Department of Health on something called QUIP, which stands for Quality, Innovation, Productivity and Prevention. In some ways, at its worst, it was shorthand for how much money can we pull out of the system. So that was what was happening for me as I joined the team, which was called the Corporate Improvement Team. And obviously, because I had this challenge of leading on culture, I became very concerned that as an organisation we weren't really defining what culture we wanted, and we certainly didn't appear very clear about the culture that we had. So I began to look at the literature and began to challenge really what we meant by culture, and that we really certainly had to define what culture we wanted to move towards, and then have some kind of measure to begin to assess how far the gap would be. Some of the reading I did, it didn't seem to link the aspect of culture to high performance, and it often seemed to talk about atmosphere or climate, and seemed quite sort of soft in its focus. So for me, I asked some of the business schools to do a literature review, and one of the business schools in Newcastle came up with this, the Denison Model. I liked the language, I liked the fact that it was holistic, it gave us a framework, and it seemed to me very business orientated. So I wrote a paper to the board and convinced them that this would give us a good definition of what we meant by a good culture, which was linked to culture for high performance. And asked the board whether they would agree to do a survey in the first instance to begin to get at least our baseline assessment of where our perceived culture was in relation to the 12 traits that Denison talked about. And so we did a survey, and then for me, I felt very strongly that you couldn't just stop at a survey, so I liked the idea of creating that dialogue, and the Denison guys were very firm on the survey is just the beginning, and what really matters is the dialogue, particularly around the cultural conversations. So the survey for us turned into a focus group, and then I also purchased the change monitor process, because it didn't seem to make any sense for me to do a one-off survey and some focus groups and then not be able to go back and to assess the changes that you were making and the impact they may be having. And even more important, segmented against directorates and grades maybe and locations, which was important for us. So let me just take you through, back in April 2009, we ran our first survey, and here are the results. So we had 271 people out of around 500 complete it, which I kind of felt was reasonable. It was just over kind of 50% of our staff. And we had a letter out from the chief exec saying that this was important, and certainly around kind of 150 of those staff were in the provider arm at that point, not purely commissioning. So I wasn't really anticipating too many of them seeing quite the relevance for them, because this was a particular survey for commissioners. So that seemed okay. So the overall profile indicates a number of areas that are in the average or slightly above average. We tended to have a slightly stronger external focus with higher scores in mission and adaptability, but with the notable exception of customer focus. Now, for our survey, we really don't like the word customer in the NHS, so we changed that to stakeholder focus. Apparently this profile is often one of kind of organisations in transition. Now, I think any National Health Service organisation is possibly consistently in transition, so that seemed to kind of chime for us really. We obviously had a strength in creating change, and that suggested to us that our employees were open to new approaches to do their work and improved, really had a desire to improve processes. And I think if the NHS has anything, a major advantage in its workforce is that most people are there to make a difference and feel quite passionate about that. Coordination and integration was another one of our relative weaknesses, and as I said before, that for us really needed to link in with our business commissioning flow and how coordinated we were across that. And often there is a connection between customer focus and coordination, which seems to make sense. If you're not clear about who your customer is, then maybe there will be less incentive to combine your coordination in order to deliver for them. So some of the implications then for us that were suggested by the model, and these certainly seem to resonate with some of our staff that we then went to talk to in the focus groups. Change may be seen as self-serving and not connected to the interests of the stakeholder. That a lack of coordination and integration can reduce some of our efficiencies, and the quality of the services delivered. That there's often a stakeholder satisfaction is lower than desired, and we would certainly sort of resonate with that. And the whole idea about clarity around empowerment and where employees can impact and influence, and certainly that came out from some of our focus groups from our middle managers, and I'll show you their results in just a while. But you know, we were strong on a shared sense of mission, and if you're going to start anywhere as a strength, that seemed quite an encouraging place for us to start with, and that certainly seemed to offer a foundation that we should be strengthening and leveraging. Some of the characteristics that change have difficulty getting traction, and people talk about flavour of the month. We were quite a kind of a bold organisation that that liked the idea of being quite sexy, I suppose, having the latest kind of, you know, we like to innovate, and that certainly felt like we were doing an awful lot of change, and maybe without that real focus on who we were changing for. Employees talk about silos and frustrations. We'd already picked up from some of our other analysis that our cross-functional working was really not as good as it could be, and we were designed in a silo way, and directors had that silo kind of approach with some of their directorates, and the business commissioning flow really challenged us to think across that vertical integration. Certainly some of our stakeholders were saying they were frustrated about being heard or respected, and employees did really talk about feeling underinformed and express that as a frustration. But once again, the stronger sense of mission provided a connection and a starting point. So that was our first kind of summary, really, our survey. And I suppose my challenge to you guys who are listening is, you know, if you were that CEO faced with those as a result, you know, what would be going through your mind? Would you be thinking, okay, well, we're pretty good on mission, and we're kind of just slightly over the average with one or two exceptions, and I'm kind of happy with that. I mean, obviously, there's always a risk when you go out and ask your staff what they think, that they actually tell you. So, you know, I'd just like you to think about in your own head what you would be thinking if you were the CEO of our organisation. So let's have a look at Chapter 3. So what were our challenges and our opportunities with those kind of survey results back in April 2009? So some of the challenges that we knew we had was, how do we take a complex business, and indeed a new business? There weren't many commissioners out there. It was a new kind of set of skills, and simplify that to staff and patients and customers, you know, who can understand it. How do we explain it to somebody who lives in County Durham and Darlington about what we actually do with their £1,700 each year on their behalf? And so for us, quite a lot of work went into our business commissioning flow. We knew we had to align our leaders to know and share the same story. So, you know, where were we hoping to go, and how could our leaders and our directors really be clear about, did they all mean the same thing when they talked about culture, and did success look the same to all of them? How do we engage our people and gain commitment to contribute to the delivery of those business objectives? So certainly coaching was one of our major interventions, about people being really clear about what their priorities were and the objectives that they wanted set. And we also knew that we had a culture of accountability that was motivating and recognise success when we don't have something like a profit and loss to motivate us. So we did quite a lot of work on our appraisal process, and how do we take work roles and team objectives, and indeed how do we even begin to move towards team appraisals rather than individual appraisals. In a complicated business, it's rare that individuals can achieve a complex aim. We also needed to know, you know, we were aware that we needed to become much more coordinated and integrated in our across our business commissioning flow and in our program management office. And how did we keep our customers at the centre of our decision making and actions? So, you know, one of our major challenges was to build this culture that drives high performance. And Denison really did help us define what we meant by a culture that could really relate to high performance. And all of this within, you know, what was a 38% but moved up to 48% reduction in funding over the next 3 years. So we had some of our challenges ahead of us. So, so we did our survey on 271 people, and then for our focus groups we felt it was important to not just do our donut of doom, which is a term I inherited from the Denison crew, and for us we kind of like it because it's very descriptive. So we wanted to look at our good practice as well as the groups. We segmented by directorate, so which directorate people were in, what grade they worked at, and where they were located. And we were anticipating that location, because we had a head office, we thought that maybe distance from the head office would have a significant impact in the cultural perception, that whether you were more senior or the furthest away you got from strategic decision making may impact on your perception of culture, and indeed the directorate and the director that you worked with may have that same impact. So our best practice sat with the clinical directorate that was led by a general practitioner, and we then chose our lowest scoring other segmented groups. So our grade 7s would be our middle managers, so they are just below our assistant directors, and apparently it's quite common for that middle management because they're strategic enough to have to be concerned about the strategy, but operational enough to have to manage and disseminate the strategy to lots of other people. So they seem to be telling us something quite strong in their survey results. And I'll just bring your attention to the practice-based commissioning group. Now these were where our clinicians sat, and they were probably our lowest scoring group per se, and obviously this is particularly important for us now in 2010 with liberating the NHS, which is now going to put the commissioning responsibility back in the hands of clinicians. So we knew that we had to go out quite quickly to talk to these groups. The other two, the top right and the bottom left, are the location groups, and these were the other bases that we had that seemed to be very disconnected from the perception of the culture from head office. So we did those 5 focus groups, learnt an awful lot and got quite a lot of credibility, certainly from the practice-based commissioning guys, for going out and having that dialogue and debate with them, and that led into some rules of engagement and some interesting learning around trust and some beliefs and assumptions that obviously sit at the middle of the Denison model for us. So chapter 4 is about the journey we needed to make then, and certainly within our organisational development strategy we decided to try and be quite brave and set ourselves a target as to what we wanted our survey to look like by 2014. We knew we had to focus in on coordination and integration as our focus. We had an explicit aspirational future state which sat in our organisational development strategy, and for me, I think working as an OD practitioner, why I love the Denison model is that it gave me such a fantastic framework, because I really didn't find any intervention or any improvement work that anybody was doing that I could map onto the model itself. So wherever anybody was interested and wanted to start from, you could come in on that model. So for me, it provided the framework of any organisational development work we were doing. We also were able to map it onto world-class commissioning competencies. Now these were 11 competencies that we inherited from our Department of Health, and what I found is that anything I inherited from the Department of Health or other strategists, you could just quickly read through and allocate those particular aspects to one of the 12 traits within Denison. So for us, the Denison became a very quick and accessible framework that people could begin to have that dialogue around interventions and improvements on. This slide really just shows against the 4 quadrants of Denison the 11 OD priorities that we came up with, and how we then related that back to the segments of Denison and our score within it. So for me, certainly, as I knew we were going to repeat the survey, we could see how we were improving on these aspects once we set a clear intervention path. And then we had sponsor directors for each of these OD priorities. This next slide is really just a visual, just to, this was our thinking, where we could again put Denison at the centre and also relate it to the QIP, the Quality, Innovation, Prevention and Productivity Agenda. And I think what it did for me is, because we're an organisation that loved to create change, what we seldom did was to link that change back to a consistent framework. So certainly Denison helped us provide that, and kept the conversation kind of linked back and slightly more coordinated than it had been previously. So Chapter 5 then, what was the role that we needed to play if we were going to move this our understanding of culture forward? In April 2009 we did our baseline survey. We created executive summaries that were developed and distributed to each director. So each director got their much more detailed analysis for their own directorate, and broken down to grades and location for their team. We held focus groups in the July, and we held 5 of those. We presented the survey to the leadership group, which was the directors and the direct reports, and we worked with Brian Adkins, President of Denison, to hold interviews with directors after our leadership group. Focus group notes were sent to focus group members for checking and for their approval, and the focus group report was sent to our CEO in September. Now what we've done since is also to link the Denison Leadership 360 with our leaders now for our strategic programs. Remember I said we had 5 strategic program areas, from healthy childhood right through to later life, and what we've done with our strategic program leads is now to do the Denison 360 leadership capability assessment with them, so they can begin to really drive, understand their own leadership needs, and how they begin to take those 12 traits seriously and really drive their leadership behaviour to enhance those scores on our survey model. And we've also now started working with a group of occupational psychologists to begin to look at that beliefs and assumptions in the middle of the model, and we've taken those same strategic program leads and we're looking at their ability to maximise engagement and relationship management by looking at emotional intelligence and looking at staying in the reds and green choices that we make. So I feel very strongly that emotional intelligence has a large part to play in that beliefs and assumptions that sit in the middle of that model, and I really like the idea that the 360 leadership capability assessment could be linked to the organisational culture and could really kind of challenge and support our leaders to take on that role of developing that organisational culture. So in terms of the progress, it was suggested, some of our quick wins was that we would produce a report on the focus group findings, which we did, that we fed back to the members of the focus groups, which we did. There was a suggested that our CEO should send a thank you out, but sadly I think that was one of our lessons to be learned, is how do you keep this on the agenda of the CEO. I think because we were kind of average, I think it was easier to let that need to thank the staff slip. We had storyboards displayed in all our locations, and on the back of that 6 chapter storyboards we had in all of our locations, including the locations that had the lower survey results, and we then put our survey results on the back of chapter 2 on our storyboard, which every member of staff got a copy of. We challenged our management group to be more visible across our locations, but we failed to deliver that one. We developed a concise business overview, so we took our 190-page strategy and made it much more accessible to staff in a delivering our strategy staff briefing, and we reduced our 5-year strategic plan. We conducted monthly cultural conversations, and certainly engaging in monthly directorate discussions. We had 2 or 3 maybe directorates that really got quite excited about the survey results and developed a regular discussion, cultural kind of conversations within their directorates about the need to move forward and develop that and change it. In the midterm goals, we did conduct the change monitor, and we're doing some follow-up action planning in directorates, but we really didn't do much with the management and leadership group development. The next slide really gives you a copy of our corporate checklist, because I felt very important that we needed to give people a feasible first step to, if they were going to think about the 12 traits of Denison, what would they need to consider personally. So certainly we knew that coordination integration was low from us, so the BCF around coordination integration, we asked managers at their one-to-ones and appraisals and job reviews to go through with staff and ask them whether they understood the BCF and who leads each step. Do they understand who contributes to that? So there are several questions around the 12 traits that give staff a corporate checklist that they can discuss with their line manager to begin to put a feasible first step into changing their understanding of those traits. Now, we repeated the survey again in May 2010, but we only went out on 3 of our measures. Coordination and integration, because the business commissioning flow was our main intervention for that. I wanted to look at our empowerment scores, because that should have linked to our coaching, was our main intervention, and we had 170 people through the coaching program. And I wanted to assess a team orientation, because we were doing lots of work around team objectives and setting KPIs, key performance indicators within teams. And as you can see, when we went across, I didn't go out to customer focus because I didn't feel that we had a strong enough intervention to change any of that perception. The good news was that we then had 390 people complete the survey. Obviously there was less questions, but people had felt that enough had happened from the previous one to merit doing so. But our results had gone down, and I think this was really a challenge back to the board and the leadership group, really, that when you aren't focused in on the things that staff are telling you need to change. So we were still saying our approach to doing business wasn't consistent or predictable. Now, because we'd done so much change on the business commissioning flow, we felt that maybe that was influencing the results, but you know, we still needed to be acknowledging that we didn't have good alignment of objectives across levels. Now, it may be that once the BCF is established for a bit longer, these results started to go up, and certainly some directorates were much stronger in their results than other directorates. So, Chapter 6, where were we trying to get to? We knew that if we had to sort out our communication, we had to share information about projects, initiatives, goals across the organisation. We knew that we had to look at touch points or handoffs, particularly against our business commissioning flow. So we needed to improve that, and we needed to include agreements on the norms for behaviours, decision makings and conflict resolution. We had to have shared strategies and transparent goals, because good organisations that have high coordination integration will have that, and we needed our senior leaders modelling collaborative behaviour. We also needed role clarity, and trust was absolutely essential. So when people trust one another, they're more likely to collaborate and communicate freely. Now, obviously, when you're getting rid of a 48% of your management costs, trust has really kind of quite suffered over the last couple of months. We knew in terms of our leadership that we had to have good leaders that could define our core values and communicate them and live them out. So we really had to do some work on our 5 corporate values that we had. We had to look at how we reach agreement and how we reconcile differences by promoting constructive discussion. We don't do robust discussion very well in the NHS, and we had to improve on that. And we had to manage our coordination by ensuring different functions or units of groups work well together. So we knew that that was our major challenge. And again, putting Denison at the middle of that and linking that with our 360 helped us gain some clarity. Now, for our major leaders, the whole QIP agenda and pulling money out of the system became a kind of a key priority, and I think where we were failing to motivate staff was the fact that QIP became seen as just the finance. And we worked with the Denison team to begin to say, okay, how could we map QIP onto your Denison model? So the bottom half of the model is about high quality of care for all, and we then had aligned our organisational development priorities that began to look at how we did high quality of care for all. In terms of innovation, that was the left-hand side of the model, so our adaptability and involvement. So how do we create an environment in which change and improvement can flourish? And productivity looked at the right-hand side of the model, so how do we begin to design and implement more efficient and productive services that do not compromise on the quality and safety of patient care, but rather enhance that patient experience. And finally, for prevention, which we're very conscious of in the NHS, how do we shift away from diagnosing and treating towards predicting and preventing? So some of our lessons then were really about, for me, that you absolutely have to start at the top. Now, I suppose one of my frustrations is that I had to go through a director in order to get to the board. And I suppose if I was going to do this again, I would want direct access to the board with a contracted feedback process on progress and commitment. How do you align and empower the directors? As I say, some of our directors loved the model and really took it on board and loved the feedback that they got from it. Other directors were less engaged by it. And certainly for me, I think dialogue is key. Go out there in the dialogue as quickly as possible. Focus groups were great mechanisms for that, and set up a mechanism where you have that regular cultural conversations. The best thing about Denison for me was the framework, that you could start anywhere on the model, that people could hang the initiatives that they'd already started in the organisation, and it began to increase the coherence. Start where the energy lies, and actually the measurement was motivating for us. People like to know whether they're making a difference, and for those people who are making a difference when even the organisational survey didn't appear to be, that was very encouraging. Okay, I think I'm probably 2 minutes over my time now, so I'm going to stop there, Karen, and now back to you.
Thank you, Karen. That was a wonderful presentation with so much information to go through. We do have several questions that have come in.
Okay.
A few questions around the support you had from the top. So can you talk a little bit more about what kind of support you did have? At the beginning, middle, and end, and what might have been different.
I think for me, my director was very supportive, but I think because I was much more hands-on with the survey and the model, I suppose in all fairness, I'm not sure she could tell the same story to the board that I would have told, because maybe I wasn't quite so good about telling her the story of the cultural audit survey in itself. So I think there was a disconnect between what the board heard and maybe what they needed to have heard, and maybe what they needed to have contract to in terms of committing to moving the survey on. They all loved it in principle, but I didn't feel that it was visible enough. And looking back, I probably would have done a cultural walk the wall. So I was then feeding that back on a fortnightly basis to our chief exec and the directors directly, rather than via my director at a directors meeting where agendas get very pushed and squeezed.
Okay.
So I had support from lots of people, but I'm not sure it stayed up where it needs to stay constantly. It was something easy, because it was kind of average. It was something easy to let slip a bit, or to allow each director to choose how involved they became in it.
Mm-hmm. Okay. At one point you mentioned that you did some 360s, some Denison 360s with the leadership. Can you tell us a little bit more about that process and how that interacted with the culture?
Yeah, I was very keen that, because we had the business commissioning flow, and we had 5 strategic programs, and we were just about to go into a program management office approach. I particularly wanted to do some work with the process owners of those 6 business commissioning flow boxes, as well as our 5 strategic program leads, because they were driving, for me, those 10 people coordinating that were really driving the business. So we invited them to take part in the 360 leadership assessment. And for me, really, I wanted the leaders to really start looking at saying, okay, if they're the 12 traits for our organization, how do I, as an individual leader, contribute? You know, am I particularly strong in mission? Am I particularly poor in involvement? What am I actually doing in my sphere of influence to really drive those 12 traits in the organization for the program or the process that I'm leading? And I have to say, you know, that's gone down very well, and we've done that in conjunction with an emotional intelligence assessment about their beliefs and assumptions, because why I like the Denison Model is that it did get down to beliefs and assumptions, and I think the emotional intelligence of how you manage your personality as a leader to influence culture.
Getting down to more of a tactical level on some of these things, tell us more about the experience with the focus groups. What did that add to the survey results that you got, and did that influence how people received the survey results when you were doing the debriefing?
Yeah, I think for me the survey, you know, it's great. It gave us the kind of the what, but the focus groups went into the why, and I think certainly the two that stand out were the grade 7s, because they were a very frustrated group and very pressurized, I think, and very squeezed in the middle of the organization. So and the practice-based commissioning group, I think we got major credibility from the clinicians for inviting them to the focus groups in the first place. And I think I was very touched at the level of emotion in the focus groups from the clinicians, who were basically saying, look, you know, we don't even think you trust us particularly. You know, they were really beginning to explore some of their beliefs and assumptions about the manager's concept of them and what motivates them. And that then actually led into a compact, so a psychological contract. So I then, with their permission, fed back the focus group results to the directors and leadership team and challenged them actually in their the beliefs and assumptions they did hold about them, and so that created a much more robust dialogue and enabled that kind of elephant to be discussed. Actually, there was very little trust between the two groups, and nobody really had admitted that before, and that they needed to at least have some rules of engagement as to how they were going to be with each other. And obviously now we're in this new policy agenda where the clinicians are going to be leading the commissioning process. That's proved quite an important foundation for that relationship.
Good. Again, from that tactical standpoint, the change monitor results going down, how did you manage that?
Well, I think, yeah, I mean, we, because more people had, you know, we had almost just under kind of, you know, twice as many people do the survey the second time around. I think people in some senses felt that was a fair assessment that it had gone down, because we had completely redesigned our business process. So, you know, having taken 100 people out to look at the value stream map and then put in this new process, I think people felt that it was quite a scary thing to do, and I think we challenged the leadership that they'd kind of we'd done lots of work, and then like anything in our organisation, we start something and then we don't see it through. It kind of becomes, we move on to the next new idea and don't then follow through on the old ones. So I think there was quite a lot of reassurance from the people that said it had gone down, and quite a lot of hope that then that would remind people to look at that coordination and integration score back on the agenda. But obviously with all of these things, we then were hit with 48% management costs and losing, you know, half our staff. If anything, you could argue that that's even more important to remain aligned and coordinated, because where 4 people were doing the job 6 months ago, they're going to have 1 person doing the job from November. So coordination and integration would become even more important. But I think, sadly, I think it's only individual directors who are really picking up on that change monitor survey, particularly the public health director, and there's no real mandate from the leadership group of the directors to do that collectively.
Okay. How did the board receive those that dip in scores?
Yeah, I sadly have to say I don't know, because I didn't take them there. My boss took them there, and I'm not even sure they debated them for very long.
Okay.
And that's part of my frustration, I think, which is my main learning, that, you know, I think to contract to do these surveys, I think you have to have the ear of the chief exec and the board signed up with a very clear approach for doing that.
Okay.
Because I think you do have to understand the survey in order to communicate it with the key messages. So, you know, I think that was probably my failure to do that.
As far as your communication strategy with the organization as a whole to try to, I guess, sell the Denison, what kind of strategies did you employ to get everyone kind of talking the same language, all on board with that?
Well, I think for me, I used our organizational development strategy. So, you know, Denison sat very clearly in our 6-chapter corporate story. That was chapter 2 about our current performance, and we had that, you know, visually that was on the back of the story card that everybody got. And our OD strategy was geared around the whole model. So, and then the challenge for me, back to our director of strategy, was to say, you know, that story, Denison needs to be in our corporate strategy, and certainly within our story. So I geared our whole organizational development strategy around the model, and our prioritization was around our weakest scores.
Okay.
With the exception of the, you know, customer focus, you know, that was one of our priority areas. So, and coordination integration. So for me, it gave our OD strategy a framework and focus, and then obviously people took the OD strategy seriously, and then that picked up the momentum. Yeah. Okay.
All right. I think we have time for one more quick question.
Okay.
If you could hit rewind, what's the one main thing that you would do differently?
I would want to go into the chief exec's office myself.
Okay. Somehow I knew that was going to be your answer.
Okay.
All right.
Thank you. Thank you very much, everybody.
Well, thank you very much. We really appreciate you sharing your story and all the challenges and the opportunities you've had with using this within NHS. And for all of those out there, all of you out there listening to us, if you have any questions or would like to learn more, I encourage you to contact us, and we will get your questions to Ms. Jones.
Yes, I'd be delighted.
So thank you for joining us today, and I'd like to also let you know that our next webinar is going to be on Wednesday, October 27th, again at 11 Eastern Daylight Savings Time. For that webinar, we're going to be joined by Stuart Hart. He's from Cornell University, and he's a leading expert on sustainability. His recent book is Capitalism at the Crossroads, and it's very, very interesting. So keep an eye out for more information on that, and we will be sending out invitations to all of you. So once again, we really appreciate you all taking the time to be with us today, and we look forward to having you all at a future webinar. Thank you, Karen.
Thanks. Bye-bye.
Bye-bye.